right, we are moving along excellently. We are actually ahead of time. I want to thank our cardiologists for those very specific and expert opinions on their world. It really helps make things a lot more clear. In this last section, we're going to focus on the medical management, change the equation on PAD risk factors. And as a vascular interventionalist, a vascular surgeon, we tend to do things that we do well, and that's fix arteries, fix veins, whatever, fix the heart if that's what our focus is. And we're fixers of things. And so one of the things that we have to recognize is that it can't just, I tell my patients, I can't just be a plumber. I need to fix the underlying reasons why that we're having problems. And so the focus on the changing the equation of PAD risk factors is critical. There are many people that have PAD that are unrecognized, undiagnosed, and then therefore untreated. So how do we work together as a collaborative group? We are trying to establish a medical side of the practice where that's not in conflict with any established PCP, but really in collusion with the PCP and cardiology world to establish a community clinical network for a lot of these patients. So our next topics, the first topic will be by Laura Kirk. It's going to be the cholesterol question, right numbers, right treatment. And Laura is one of our latest acquisitions at Vic. She has a decade of critical care and emergency care experience. She received her master's from University of Tennessee, Chattanooga. And her experiences are as a flight nurse on Life Force. We're very happy to have her involved with this. The next topic will be diabetic care and escalation of therapy. Marisol Thomas has been with Vic for a couple of years, and she's bilingual, Spanish, English, and has been a great benefit to reach the Hispanic communities. She's also had her master's from University of Tennessee, she's graduated from University of Tennessee, Chattanooga, but had her master's from Southern Adventist. And she's done quite a bit of work with diabetic patients, working as a nurse practitioner in a medical clinic for years. Roxanne Phillips will be talking about the great smokeout, as well as vaping. And she's been with Vic for 3 years. She's been her main objective this last year was establishing our North Georgia office. She's a certified adult gastroenterology primary care nurse practitioner who's also achieved her doctorate in nurse practitioning. And she's actively involved as a member in many cardiovascular organizations. Now, following that, Stephanie Sheridan has had tremendous experience. She has her doctorate in nurse practitioning as well. She'll be talking about hypertensive management and developing a plan of care, and has been with Vic for about 4 years. She also has her doctorate degree from Southern Adventist, and she specializes in vascular dialysis care and nephrology-related issues. She's been our primary driver for the Cleveland offices and is available there most days. And lastly, Veronica Osteen, not lastly, but of course, next is Veronica Osteen, role of anticoagulation and antiplatelet therapy. What are the modern rules now of how to deal with this? And she's been an anchor at the Vic team, graduated from Southern Adventist as well. And then she's certified emergency nurse and board certification for emergency nurses. Lastly, we're going to have Dr. Robert Hedrick speak about lung cancer early detection that saves lives. We're going to put him in his own special section because this is a critical issue. And many of our patients that are PAD patients are smokers in this region. And so who should we screen? How should we screen? And I'm hoping we get those answers from Rob here shortly. But he's the chief of thoracic surgery and the medical diet leader of oncology services at CHI Memorial Reese Gillerin Cancer Institute. He has an undergraduate degree from Vanderbilt. He has obtained his surgical residencies at the University of Tennessee and his fellowship in thoracic and cardiovascular surgery at Mayo. I'm looking forward to his talks. So we're moving. It is Friday afternoon. I would say that I'm amazed that we've retained 90% of the participants from this morning, and hopefully that this has been good for this community. And I thank you for all the doctors that are participating and all the people that are participating. So without further ado, let's move forward with our afternoon and last session. Thank you.
Hi, I am Laura Kirk. I'm a nurse practitioner here at the Vascular Institute, and I'm going to talk about cholesterol and PAD. Atherosclerosis is a systemic disease. Approximately 42% of patients with coronary artery disease also have PAD. The patients with PAD are at higher risk of an eventual cardiovascular event or death, especially if they are symptomatic. The risk factors of these diseases overlap, yet many providers are not as aggressive when treating patients that are suspected of having only PAD. In the 2018 AHA-ACC guidelines on the management of cholesterol, symptomatic PAD is classified as a major ASCVD event. Most providers are proficient in recognizing the risk factors associated with MI or stroke, but as shown, these risk factors are also associated with PAD. Therefore, we should be just as aggressive in treating. When calculating a patient's ASCVD, you look at many factors that are easily attained during a provider's assessment of the patient. Based on the calculation, a provider can determine if the patient needs a moderate or high intensity treatment regimen. The calculator is easily findable using a Google search. As we know, lifestyle changes are the first step recommendations and should be included in all treatment plans in the management of cholesterol. Tobacco cessation, diets high in vegetables and fruits, a lesser amount of animal products, and minimal red meat should also be advised. Exercise is another important aspect. When we are considering starting a statin or other medication to reduce cholesterol, looking at the 10-year ASCVD risk can help determine where to begin. When it comes to the low-risk population, providers should be cognizant of their patients' risk-enhancing factors. But when it comes to PAD, we know they're already at the high risk for subsequent events or sequelae of the current disease. Statin therapy is needed in the PAD population. With patients in the intermediate category, a moderate intensity statin may suffice. But with our patients and those with other cardiovascular risks, the focus needs to be on reducing their LDL by at least 50%, which requires high-intensity statins. Patients that have already experienced a major atherosclerotic event require even stricter control. These patients should have a goal of less than 70. The Endocrine Society recommends diabetics should strive for less than 55. There are many options for statin therapy, but for patients with PAD, we prescribe atorvastatin 40 to 80 or rosuvastatin 20 to 40. The high-intensity statins do increase the risk of developing diabetes. Baseline liver enzymes are recommended, but hepatic dysfunction is rare. If a patient reports muscle aches and weakness, especially with increased CK levels, the statin should be discontinued. You may be able to restart it after a few weeks, but maybe start at a lower dose. These patients could also benefit from adding a non-statin to their regimen. Zetia inhibits cholesterol absorption and taken alone shows a near 20% reduction in LDL. That increases when taken in combination with a statin. Repatha and Praluent are PCSK9 inhibitors and inhibit the LDL receptors from breaking down. They have drastic results with LDL reduction. These are all good options if the patient's unable to take statins or is unable to reduce their cholesterol with monotherapy. The other option is to reduce the statin dose to reduce the risk of side effects and add one of the other non-statins. The good thing with the PCSK9 inhibitors is they've not shown any association with developing diabetes. The heart protection study that was published in the Journal of Vascular Medicine in 2007 showed a significant reduction in vascular disease with just simvastatin alone. Over 20,000 people aged 40 to 80 were included in this study. These patients already had a diagnosis of peripheral artery disease, coronary artery disease, cerebrovascular disease, diabetes, or hypertension. PAD in this study was defined as intermittent claudication, or those that have already received a revascularization procedure or amputation. Exclusions were patients that could not have statin therapy, or those who had an MI or stroke within the past 6 months, or other conditions that would interfere with the patients being able to comply with the therapy for a prolonged period of time. The shaded portion in the graph represents the number of people having a revascularization procedure within 5 years. The S is depicting those that are taking simvastatin. As the graph depicts, patients on simvastatin show a decreased risk of future vascular events. The IMPROVE-IT trial showed adding Zetia to simvastatin reduced the rates in long-term cardiovascular events, which includes PAD. This study looked at a little over 18,000 patients that were 50 years of age or older, already had at least one risk factor such as diabetes, PAD, or CVA, as well as patients with an LDL that was between 50 and 120. All the patients were on simvastatin 40 and were given either Zetia 10 milligrams or a placebo. Within either group, if the LDL was greater than 79, simvastatin was increased to 80 milligrams. The average LDL reduction was 24% when compared to the monotherapy. When looking at vascular events that occurred, the majority of the patients experienced no events, and less than 6% had more than 2 events. So if this is placed into a 10-year time frame, for every 100 patients on dual therapy, 11 patients did not have any kind of vascular event. These accounted for 4 MIs, 4 revascularization procedures, and 2 strokes. Cardiovascular death and unstable angina did not show a significant reduction. The 48 trial looked on how Repatha was at lowering LDL. In this study, there were over 27,000 enrollees that had an LDL that was greater than 70 and already on a statin therapy. 69% of that population was on a high-intensity therapy. Atorvastatin 20 milligrams was the minimum dose accepted in the study. The participants were randomly chosen to receive either placebo or Repatha. The Repatha was dosed at either 140 milligrams every 2 weeks or 420 milligrams monthly. At 48 weeks, the mean LDL reduction was 59%, with 87% of those patients being below 70 milligrams per deciliter. So per the AHA and ACC 2018 guidelines, the goal is to get the LDL lowered by 50%. Any patient, regardless of their health status, is considered very high risk if their LDL is greater than 190, and they need to be started on the high-intensity statin therapy. After initiation of a cholesterol-reducing medication or with any kind of dose changes, the lipids should be rechecked within 4 to 12 weeks. Once the maintenance dose has been established, a check every 3 to 4 months is appropriate. With PAD, the American Heart Association and the American College of Cardiology recommend starting with high-intensity statins, which would be like atorvastatin 40 to 80 or rosuvastatin 20 to 40. If this is not effective, the recommendation is to start Zetia. You need to trial Zetia prior to starting one of the other ones, the PCSK9 inhibitors. And as vascular specialists, this is part of our specialty. This is our regimen. Our patients are already high to very high risk, and our aim in their cholesterol management, it needs to coincide with their condition. We aim to prevent further vascular damage and to focus on the promotion of a better quality of life. Thank you.
Good afternoon. My name is Marisol Thomas. I'm a nurse practitioner with Vascular Institute of Chattanooga. Today, I'm going to be discussing diabetic care and the escalation of therapy with peripheral artery disease. The objectives of this lecture is to identify the patient population at risk for diabetes and vascular complications, understanding the process of vascular damage with diabetes, management of diabetes with peripheral artery disease, and understanding that early intervention is crucial for limb salvage. Who is at risk? According to the National Diabetes Statistic Report for 2020, crude estimates in 2018 demonstrate diabetes affecting more than 32.4 million people in the US alone, with higher prevalence in the southern states and the Appalachian region. People of lower socioeconomic and education level are at greater risk of diabetes and related complications. Age plays a role in the prevalence of diabetes. People greater than 65 years of age have a higher prevalence at 26.8%, followed by 17.5% in the 45 to 64 age category and 4.2% in the 18 to 44 age category. American Indian, Alaskan Natives have a higher prevalence of diabetes, followed by African Americans, Hispanic, and the Asian population and the Caucasian population following that. The following is a chart showing the pathophysiology of the effects of diabetes on the endothelial layer. Vascular diabetic complications are mainly due to prolonged exposure to blood sugar accumulation with other risk factors such as arterial hypertension, dyslipidemia, and as well as genetic susceptibility. Specifically, endothelial dysfunction is associated with reduced nitric oxide production, increased anticoagulation properties, increased platelet aggregation, increased expression of adhesion molecules, increased expression of chemokines and cytokines, and increased reactive oxygen species production from the endothelium. These all play an important role in the development of diabetic vascular complications, including atherosclerosis and other vascular pathologies. Importantly, endothelial dysfunction has been shown to be prognostic significance in predicting vascular events, including thrombosis, inflammation, and atherosclerosis plaque formation. There are long-term negative effects of diabetes on the vascular system. It affects both the microvascular and macrovascular. Microvascular complications include retinopathy, nephropathy, and neuropathy, while macrovascular complications encompass coronary artery disease, strokes, and of course, peripheral artery disease. For the purpose of this lecture, we are focusing on the macrovascular complications with PAD. Diabetics are at a higher risk for lower limb amputation compared to the non-diabetic population, typically about a 25% higher rate. Lower limb amputation includes toe, foot, below the knee, and above the knee amputation. Diabetic foot ulcers and non-healing sores are the initial event in 85% of cases. Of those, 25% require some form of lower limb amputation. Mortality rates are higher in the diabetic with an amputation history. Up to 50% of people will live less than 3 years following an amputation. Usually, these patients tend to have other chronic comorbidities such as hypertension, end-stage renal disease, and poorly controlled diabetes. Factors affecting lower limb amputation include A1C greater than 8%. Again, elevated blood sugars have damaging effects on the endothelial layer. When other factors are eliminated, a 1% elevation in the level of hemoglobin A1C is reported to increase the PAD risk by 28%. Previous studies have shown that compliance with treatment of diabetic patients have been steadily decreasing over the years. While oral anti-diabetic therapy, diet, and exercise are first steps in diabetic treatment, because this causes fewer fluctuations in blood glucose level, insulin therapy tends to lead to much higher, more common fluctuations in patients. So insulin use tend to have more effect on amputation versus non-insulin use. Diabetic neuropathy and PAD are seen in 45% of patients with diabetic foot ulcers. Many patients may develop an ulcer and not even know that it is present due to neuropathy. Ulcerations and wounds that are complicated by osteomyelitis and/or infection increase amputation rates by 15%. Due to higher blood sugar levels, wounds and ulcerations that are infected tend to heal very, very slowly. Ischemia is a decrease or loss of perfusion to the tissue. With quick vascular intervention, perfusion can be restored. However, if the tissue becomes gangrenous, tissue is lost and would require amputation or further debridement. The following table demonstrates amputations related to diabetes and peripheral artery disease complications. It is broken down by toe, foot, below the knee, and above the knee amputations. As you can see, there has been a steady rise over all these different types of amputations over the years. Early prevention is vital for successful outcome with limb salvage. Early screening for PAD is recommended. Patients that are 55 years or older with risk factors or 70 years without risk factors are the target population. Assess for PAD risk factors. These include diabetes, hypertension, hyperlipidemia, coronary artery disease, and tobacco use. 20% of our diabetic patients have PAD. Screening is performed with an ABI, ankle brachial index. The following chart demonstrates normal and abnormal values and when it's important to refer. Just be aware, though, that calcification or hardening of the vessels can give falsely elevated readings. And you can see this a lot with our diabetic patients. If a patient has a wound or an ulcer with a normal ABI, additional screening should be obtained. Observe for flow, feeling of pain in limb, loss of sensation in the feet or toes, open sores, ulcers that are slow to heal or will not heal, weakness, cramping, or trouble walking. Remember, improving blood flow within 8 weeks of an initial psoriatic ulcer has the greatest outcome potential for wound healing. Waiting to be seen by a doctor for diabetic foot ulcers for longer than 6 weeks can increase the likelihood that the ulcer will result in an amputation. Studies have demonstrated that endovascular intervention for our diabetic patients with ulcers or wounds have the greatest outcome potential for limb salvage and healing. Endovascular treatment can include bypass surgery or angiogram. There is a 70 to 90% limb salvage rate within 1 year post-intervention, and up to 60% of ulcers are healed within 1 year post-treatment. Life expectancy is 60% higher in our diabetic patients that undergo endovascular intervention. The ADA recommends a target hemoglobin A1C below 7%, excuse me. Ideally, it's about 6%. A preprandial plasma glucose goal of 80 to 130 milligrams per deciliter and a postprandial goal of less than 180 milligrams per deciliter is also recommended. Lipid and lipid protein profile reduction is also necessary. LDL is recommended to be less than 70 milligrams per deciliter, with triglycerides less than 130 milligrams per deciliter. Blood pressure management is also crucial with our diabetic and PAD patients. Blood pressure is recommended to be less than 140/90 blood pressure. Guidelines also recommend that our diabetics require A1C monitoring every 3 months. Physical activity is also important. It is recommended that 150 minutes of moderate intensity exercise is performed per week. Avoid smoking and complete a smoking cessation program if possible. The importance is to try to prevent diabetic complications with wounds, which can lead to amputation. These are my sources. Thank you for your time.
Hi, I'm Roxanne Phillips. I'm a nurse practitioner with the Vic Vascular team. I'm going to talk to you about the Great American Smokeout and vaping. So I'm a certified adult gerontology, primary care nurse practitioner, a health coach, and I earned my doctorate of nursing practice degree in 2019 from UAB. I work for Vascular Institute of Chattanooga. I have for about 3 years, and I've implemented smoking cessation at this facility, so I'd like to share some of my experiences with you guys. There's my contact with my phone number, cell, email, and office. Feel free to text me or call anytime with any kind of questions about smoking cessation or just vascular in general. I had to give a shout out for our new office that's opening. It's going to be in Ringgold on Battlefield Parkway, and I'm very excited about the new building. The move-in date is November 16th. All the conditions that we treat I've listed here. I don't know if it's a coincidence that almost all of them are made worse by or caused by smoking, so it's very relevant to this talk. Our objectives, we're going to talk more about the Great American Smokeout and what that is and how we can use it to help motivate our patients to be successful in quitting smoking. The negative health consequences of smoking, of course, and some statistics that are updated. And we're going to go over some of the methods for smoking cessation that can help. And also we're going to talk about vaping this year. Wow, we have come a long way. These are some cool vintage tobacco ads that I found. Stanford University has a website dedicated to just tobacco advertising research, and I think it's a good thing that we have come a long way from this. So I know we're streaming And I just wanted to give a little question. How many people still smoke cigarettes in the US? So I've got some options here. 500,000, 16 million, 32.4 million, oddly specific, and all my patients. Sometimes it seems like that on any given day. The answer is C. So 32.4 million people in the US, adults, smoke cigarettes. So 13.7% of the population. This is the map that we did last year, and I wanted to just give a shout out to Tennessee because we've moved from dark blue to light blue, still 19.4 to 22.9% of our population smokes. This just gives a breakdown of where the highest percentage of tobacco users is in the US. And there we are. Smoking kills people. 1 out of every 5 deaths can be related back to smoking. Shortens your life expectancy by about 11 to 12 years. Causes cancer. People know these statistics usually, but it's still very relevant and eye-opening. I see most of the cardiovascular problems from smoking. It's a major cause of cancer, lung cancer mostly. Most of the lung cancer deaths can be attributed to smoking cigarettes. Major public health issue. So I got to do a little research and learn about electronic cigarettes, otherwise known as vaping. They contain a couple different things. There's a battery, a heating element, and a storage compartment for liquid. They produce aerosol by heating a liquid, usually containing nicotine and some other ingredients like flavors. E-cigarettes do contain cancer-causing chemicals, ultrafine particles that can penetrate deep into the lungs that can cause other issues. Also, they can explode when they charge, so they're not safe. Scientists are still learning all the health effects from vaping, and we're going to talk a little bit more about that. E-cigarettes, most commonly used tobacco products among youth. So the young adults and youth are disproportionately affected by this. 4.9% of middle school students, and wow, 20.8% of high school students. So this came from the CDC website. They admitted to vaping within the last 30 days. One thing that I got to learn was the abbreviation EVALI. So this is e-cigarette or vaping associated lung injury. I know that this was a big thing on the news last year. So first detected August of 2019, sudden onset of a severe or sometimes fatal lung infection in otherwise healthy individuals, sometimes a younger adult or adolescent. And as of this February, total of 2,800 hospitalized cases or deaths have been reported. What the CDC found was these cases of the EVALI have been linked to chemicals. So THC can be administered in a vape or an electronic cigarette. Vitamin E, so they found vitamin E in the lungs of these people with the EVALI condition, and often that's used as an additive with the THC. And they found that more likely to have the lung injury if you bought it off the street or if you borrowed it from a family member or friend. So electronic cigarettes, vaping, not safe for youth, non-smokers, or pregnant women for sure. In general, they are not recommended, but they're, I hate to say this, but not as bad as a regular cigarette. I know that's controversial, but from all the research I've done looking at this, there's less harmful ingredients, and there could possibly be a benefit to using an e-cigarette if that patient is very motivated, wants to quit smoking, and completely comes off of regular cigarettes in order to kind of bridge that that time of smoking cessation. So let's talk about the Great American Smokeout. This event is hosted by American Cancer Society. It was started back in the 70s. There were several smaller scale events starting on college campuses, wanting to take a day to give up cigarettes. Everybody agrees to quit smoking for at least 24 hours, and the money that they would use for the cigarettes went to beneficial things for that. And so over time, it's evolved, and it's become a big deal. The American Cancer Society has used the publicity from this to help with community programs, smoke-free laws. It's held annually, so every year, the third Thursday of November. So it's coming up in several weeks, and it's a very good way to go ahead and help set a quit date for your patients that need just a little push to get them going. So November 19th. It's important because a single day can help people take that first step. So picking a quit date is sometimes put off. This is something that you tell your friends and family. You can make preparations. It brings people together. So you can use the hashtag Great American Smokeout. They have local events in various cities. This year is mostly online, of course, because of COVID. The resources are available 24/7 from American Cancer Society. The phone number is there, and also cancer.org. There's tons of helpful resources for patients that want to quit smoking. I'm not going to read all this, but I wanted to list kind of the landmarks and the progress that has been made by American Cancer Society through programs like the Great American Smokeout. So the first city to ever, Berkeley, California, basically, first to limit smoking in restaurants. That was in 1977. The first smoke-free law for plane flights less than 6 hours was 1990. And then you can see the progress that has come on from cigarette companies being called out for advertising to children using cartoons, and lawsuits being filed to the big tobacco companies, and money that's been have to pay for lawsuits for that. And in 2017, even the major U.S. tobacco companies, 11 years after being told they have to, began publishing their corrective statement advertisings, basically to apologize for the chemicals that were used in the cigarettes and the misleading. So November 19th, 2020, encourage your patients to quit smoking. Great American Smokeout is tons of information and support for them. So just quickly, I wanted to go over again, ways to help patients quit smoking. Brief face-to-face counseling has been proven to work. So just every time you see the patient that smokes, hey, smoking's bad for you, I really recommend that you quit. Please strongly consider to quit and let me know if you need help. I can offer you medication that could help, and I can refer you to smoking cessation programs, nicotine replacement therapy on 1-800-QUIT-NOW. What about vaping? I wonder if that could be helpful. I always said no. I was a big, just don't vape, don't do it all. Our office in Fort O is next to a vape shop, so we see them constantly. Guess what? FDA does not approve vaping for smoking cessation. However, it may be beneficial, especially if it's used with nicotine, and you can step down the nicotine, and then your ultimate goal is to completely refrain from smoking at all, even the electronic cigarettes. There have been a couple studies there that have shown that patients can help be more successful in quitting smoking with vaping. However, there are some studies that show they're not. We're still learning, and as of right now, you can tell your patients that only if they completely quit smoking cigarettes, and then the ultimate goal is to be off of the vape. delay, deep breathe, drink water, do something else. You got to have a plan of something that you're going to start whenever you want to quit smoking. I often tell my patients to start taking vitamins. The emergency drink that has the vitamin C and the B vitamins to help, a little boost of energy, and it gives them something to do and to think about that's helpful. We all know the stop smoking medications. Chantix is the best efficacy. It's about a 3-month course, can be used longer than that. Nicotine replacement patches plus the gum for breakthrough symptoms. Tell them, you can use both. You'll step down that dosage on the nicotine patch. Bupropion is an antidepressant that helps with smoking cessation. Clonidine and Topamax don't really use as much. However, there's an off-label use that it can be helpful. All of these drugs will help your patients be more successful. So the Great American Smokeout, tons of resources for patients and providers. There's a lot to learn about it, even though it's still bad for you. We still want patients to quit smoking. We see the negative health consequences, amputation, lung cancer, heart attack, stroke, all of that is devastating. Just be there for your patients, no judgment, but we want to, tell you what we know. It's our duty to give you this information and to help all patients by offering medication for it. And mark your calendars for November 19th for the Great American Smokeout. Thank you very much.
Hi, my name is Stephanie Sheridan, and I will be presenting the management of the hypertensive patient from a vascular standpoint. Our objectives today are to discuss the regulatory agency for hypertensive management, the prevalence of hypertension, risk factors that predispose these patients to hypertension, why do you refer to a vascular specialist, and also a quick case study. Joint National Committee 8. The Joint National Committee gives us guidelines for prevention, detection, and evaluation and the appropriate treatment for hypertensive patients. They have created guidelines for facilities and providers to follow to appropriately regulate blood pressure in our patients. If you will take a second to look at this graph, this is showing the prevalence of hypertension, specifically in our southern states, our areas right around here. Tennessee, Alabama, and Georgia all have a very high prevalence of hypertension, with 32 to 38% of the population having hypertension. Also, let's take a look and note that 103 million adults have hypertension in the United States. 90% of our hypertensive patients are above the age of 65. And there are 95,000 patients awaiting kidney transplant and 430 patients currently receiving hemodialysis. Risk factors: age, genetics, healthy drinking, race, reduction of stress, regular exercise, salt intake, smoking cessation, and weight loss. A great deal of these can be modified by changing our health habits, by exercising daily, reducing our high sodium carbonated drinks, and just reducing our stress. You see smoking cessation down there at the bottom. Smoking cessation is such a major cause of chronic diseases, which causes inflammation in our vessel. Genetics is sometimes not, hard to outrun our genes, even though we try a healthy lifestyle. Sometimes if grandma, great granddaddy all had diabetes or hypertension, sometimes it's hard to just outrun that genetic factor. Why do you refer to a vascular specialist? For resistant hypertension, And as we know, hypertension is any blood pressure greater than 130/90. Chronic kidney disease, and also fibromuscular dysplasia. All these can develop with renal artery stenosis. As we go into our second slide, we'll see that, when you're seeing these patients in the office, they a lot of times will have white coat syndrome, which will make their blood pressure slightly elevated. However, we're not looking for the slightly elevated blood pressure. We're looking for the patient that is on 3 medications and they still continue to have uncontrolled hypertension. And when I say 3 medication, I'm talking about an ACE inhibitor, a calcium channel blocker, and also a diuretic. And yes, a diuretic is included in those 3 medications. So if they're having a blood pressure 150s, 160, and they're on 3 medications, then that's the person that you need to send to us for renal artery stenosis. We can do a simple non-invasive test, just ultrasounding the renal artery to see if there's any type of stenosis noted in the artery. Renal insufficiency. Elevated blood pressure is a burden in patients with multiple comorbidities. And there's also a prevalence of hypertension when patients just have stage 1 renal disease. That's significant because 70 to 80% of those patients will have elevated blood pressure. And we want to slow the progression of renal disease because we all know that renal disease can progress to end-stage renal disease, and then they will require dialysis. And as I said on my earlier slide, there are 430 individuals requiring dialysis. So if we can prevent these patients from getting on dialysis, we want to do so. This slide shows what stenosis looks like on ultrasound. When we're scanning those areas, you see the aorta and the renal artery stenosis right there at the proximal area. The second picture shows what the stent looks like, how we have placed the stent in that area so that adequate blood flow can reach the kidney. Fibromuscular dysplasia affects 10% of patients between the age of 40 to 60. This is more prevalently seen in women, and it affects the medium-sized vessel, more commonly seen in the renal and the carotid artery, but FMD can affect any artery. The symptoms you'll see in these patients are usually hypertension that is uncontrolled, a carotid bruit, migraine headache, tinnitus, and dizziness. My case study is a 52-year-old female. She presented to my office with uncontrolled blood pressure. She was on lisinopril, a calcium channel blocker, and also Lasix. Her blood pressure on my visit was 178/89. She was found to have a right carotid bruit. When we did her ultrasound, it revealed a right renal stenosis with elevated velocities of 354. Stenosis was found of greater than 60%. Her kidney size in the right kidney was 8.45 centimeters, and on the left was 9.53 centimeters, which both are still normal. However, you notice the right kidney is smaller than the left kidney. When we scan somebody with FMD, they will have a string of beads or a string of pearls. You will often hear people say, this is what their vessels will look like. And this is also the reason that you'll hear a bruit when you listen to these patients' carotids, because their vessels are very tortuous. So post-operatively on our 52-year-old female, she did have a high-grade proximal right renal stenosis with obstruction of 80% and greater. If she was noted to find a right renal artery with FMD secondary to branch in the upper pose and lower pose. Why do you refer to a vascular specialist for hypertension? Because we often can find the diagnosis of renal artery stenosis, and with these outcomes, we can improve their kidney function up to 70 to 80%. We can improve survival rate, which slows the progression of renal disease. And we can also reduce the left ventricular hypertrophy, which causes a lower heart failure and cardiovascular morbidity and mortality rates to be reduced. Thank you for your time.
So today we're going to be talking about the role of anticoagulation and antiplatelet therapy in our patients who have PAD. So to really understand why it's important to consider antiplatelets and anticoagulants in PAD, we need to know what's happening in PAD. So these arteries are experiencing plaque buildup. It's believed that platelets play an important role in the creation of these plaque lesions, but also it's known that once these plaque lesions rupture, a clotting cascade is begun, and both platelet aggregation and thrombin become important players. So, what is our goal when we're treating patients with PAD? We want to improve their quality of life, and this means we want them to be able to feel better on a day-to-day basis, and we want them to be able to walk better. We want them to be able to be active and to live life. However, part of the big picture is that we also need to consider their risk of future events. So we want to be helping to reduce this risk of future events, namely events like cardiovascular events such as an MI, events such as a stroke, and or major limb adverse events like an amputation. So when we consider risk prevention, the Antithrombotic Trialist Collaboration was a study that showed antiplatelet therapy to be beneficial in the secondary prevention of cardiovascular adverse events in patients such as these. When we discuss antiplatelet therapy, both aspirin or Plavix are considered acceptable options. There are also patients who are Plavix resistant, and in those patients, something like Brilinta can be considered, although it's important to remember that Brilinta can have increased bleeding risks. So dual antiplatelet therapy, or DAPT, is something that should be considered on a case-by-case basis in our non-surgical vascular patients. Another option is systemic anticoagulation, such as low-dose Xarelto. And why do we talk about dual antiplatelet therapy? Well, because aspirin and Plavix work through different pathways in the body to affect platelet inhibition. And so by using a dual antiplatelet, we hope to maximize the efficacy of platelet inhibition in these patients who need it. The COMPASS trial was a study that was a double-blind, placebo-controlled study who looked at patients with PAD who were treated with a low-dose Xarelto and aspirin versus aspirin by itself. It was found that the patients who were given low-dose Xarelto and aspirin had a decreased occurrence of major cardiac events, as well as decreased occurrence of major limb events. Their bleeding risks were slightly elevated, although we did not see an increase in fatal bleeding events. So then, what do we need to consider when we are treating a post-surgical vascular patient? So it is widely known that dual antiplatelet therapy has been associated with decreased risk of major cardiac events in these post-revascularization patients. A study published by the New England Vascular Society in 2016 showed that overall survival rates were increased when vascular patients who had had surgery were discharged on dual antiplatelet therapy. The benefit was even more apparent if these were patients who had experienced a critical limb injury versus claudicants. The Voyager trial was similar to the COMPASS trial except that this considered PAD patients who were post-surgical revascularization. So that looked at post-surgical vascular patients who were given, again, either low-dose Xarelto with aspirin versus aspirin alone. And again, it was found that the patients who were given low-dose blood thinner along with aspirin experienced decreased major cardiac and limb events. Again, we saw a mild increase in non-fatal bleeding events. So it's important to understand that patients who are post a surgical vascular intervention are at a heightened risk for major adverse vascular events such as an MI, a stroke, and or reocclusion. And this is partially because we have triggered that clotting cascade by doing a vascular surgery. So the Journal of Vascular Surgery has published a data analysis suggesting that patients who are post-surgical intervention should be placed on dual antiplatelet therapy upon discharge for at least several months. Another option is the use of low-dose Xarelto along with aspirin, such as mentioned in the Voyager trial. So in summary, we need to remember that per guidelines, such as the American College of Chest Physicians Clinical Practice Guidelines, it is recommended that all patients who have PAD be on antiplatelet therapy of some sort. Again, aspirin or Plavix is considered acceptable. However, if you have the high-risk patient who, for example, has diabetes, is obese, has high cholesterol, and continues to smoke, these patients might benefit from dual antiplatelet therapy. They may also benefit from a systemic low-dose anticoagulation, such as the PAD dose of Xarelto. There is no official guidelines that recommend that we use systemic anticoagulation in these PAD patients, but trials such as the Voyager and Compass trial have shown us that this is a safe option for our high-risk patients who need a little extra help. Thank you.
I want to thank everybody for letting me be your closing speaker for the third annual conference for Faces of PAD. And I know some of you, after a long day, are wondering, what are we doing talking about lung cancer at a vascular conference? Well, I'm going to make the argument that the diseases really go hand in hand. The patients both in my office with emphysema and lung cancer have peripheral arterial disease, aortic aneurysms, coronary disease, carotid disease. The same patients in your office may have a early stage lung cancer that, with a little bit of insight, we both can help these patients out with the goal of helping extend their life and their quality of life. What we're going to do today is talk about really the power of lung cancer, and particularly early detection. It's titled Lung Cancer Early Detection Saves Lives. Well, I want to take you back to 1993 when I was in medical school and struggling to figure out what was my role going to be in medicine other than just not mess up what everybody else had done. And this very charismatic basketball coach came on TV at the ESPN Awards and gave one of the most empowering speeches of his life. 10 years prior to that, he had pulled one of the biggest upsets in the NCAA tournament, beating all the giants with a very mediocre team. Yet now he was facing the battle of his life, which was against pancreatic cancer. And he stood up and challenged all of us to start paying attention to cancer a little bit more and challenged us to start devoting more time to it. This is his speech.
Time is very precious to me. I don't know how much I have left, and I have some things that I would like to say. Now when I'm fighting cancer, everybody knows that. And people ask me all the time about how you go through your life and how's your day. And how do you get through life or each day? It's the same thing. To me, there are three things we all should do every day. If we do this every day of our life, you're going to have, what a wonderful, number one is laugh. You should laugh every day. Number two is think. You should spend some time in thought. And number three is you should have your emotions moved to tears. Could be happiness or joy. But think about it. If you laugh, you think, and you cry, that's a full day. That's a heck of a day. You do that 7 days a week, you're going to have something special. And I always have to think about what's important in life is to think, to me, of three things: where you started, where you are, and where you're going to be. Those are the three things that I try and do every day. And the screen is flashing up there 30 seconds like I care about that screen right now, huh? I got tumors all over my body. I'm worried about some guy in the back going 30 seconds. Huh? Now I look at where I am now, and I know what I want to do. What I would like to be able to do is to spend whatever time I have left and to give and maybe some hope to others. 500,000 people will die this year of cancer. And I'd also tell you that 1 in every 4 will be afflicted with this disease. And yet, for somehow, we seem to have put it in a little bit of the background. I want to bring it back on the front table. We need your help. I need your help. We need money for research. It may not save my life. It may save my children's lives. It may save someone you love. And it's very important. And ESPN has been so kind to support me in this endeavor and allow me to announce tonight that we are starting the Jimmy V Foundation for Cancer Research. And its motto is, don't give up, don't ever give up. And that's what I'm going to try to do. Every minute that I have left, I will thank God for the day and the moment I have. And if you see me, smile and maybe give me a hug, because that's important to me too.
What did that speech help accomplish? Well, over the last 30 years, lung cancer deaths have fallen by 29%. There's 3 million more people alive today than that wouldn't be alive if we hadn't started devoting some attention and changing the outcomes to cancer. And in 2016 and 17, we had the largest drop in a single year deaths for any cancer disease, and that was lung cancer, partly because of the beginning of lung screening as well as the development of immunotherapy and some of our targeted drugs. Well, what was the big opportunity in Tennessee? When we really sat down and looked at our state data, obviously lung cancer stood out as the biggest opportunity, dwarfing all other cancer mortalities. We looked at the 95 counties within our state. You're most likely to either die of coronary disease or lung cancer, and they really were neck and neck as far as the number one cause of death. In some counties, lung cancer actually prevailed. We put that in layman's terms. We essentially have one person every 2 hours dying in the state of Tennessee of lung cancer. It's now likely a female. It's equivalent to 1.5 World Trade Center tragedies per year. It's also 3.5 times our state's opioid crisis, which prior to the coronavirus was gaining a lot of attention. Well, nothing's more expensive than a missed opportunity, and lung cancer certainly carries that opportunity. We look at economic losses to the families going through lung cancer, excluding their healthcare costs, which are already astronomical, the loss from work, the transporting family members back and forth to the treatments, the radiation therapy, the chemotherapy, the surgery, the hospitalizations, the complications. It's a long journey where per year we lose about $700 million in single year Tennessee family economic losses. Certainly something that's taken away a lot of the securities of these families as well as the life of their family member. Well, lung screening data came out, trials finishing around 2010, 2012, by 2014, 15 was becoming published and discussed as far as payment from a commercial and CMS Medicare payment system. But essentially, there was no trial that didn't show a dramatic reduction in mortality, much more than any other screening tool. Mortality reduction ranged from 20 to 40%, with females gaining the largest survival advantage. We were seeing 10-year lung cancer survival rates of 90% for those who had a lung cancer found early stage in the screening program. We've never seen those numbers to date. And what was even more encouraging, it took much fewer scans to save one life. Well, the first group that was approved by CMS and Medicare and the commercial payers as far as a no-cost sharing, meaning no cost to getting the screening done, similar to mammography and colonoscopy, was age 55 to 77, a 30-pack year smoking history, and if you quit smoking, it had to be within the last 14 years. The problem is that only covered about 25% of those who are going to get lung cancer. Most people don't count the number of cigarettes they smoke per year. And certainly when they quit, it usually takes multiple attempts before they finally quit. Looking forward in 2021, looks like they're going to approve reducing the age down to age 50 and a 20-pack year smoking history, as well as equating a family or genetic history as well as environmental exposures as being a way of capturing much more people who are at risk. When this first came out, we were really expecting people just to knock our doors down, except they weren't. Wasn't they weren't going to the doctor, they weren't seeing the vascular surgeon, the cardiologist, or primary care doctor. They were just scared to look inside their body. We were letting them out of the office without a conversation about lung screening. We really looked at our state map. We also saw another geographical barrier where most of the cities or urban areas weren't where the highest prevalence and mortality of the disease was occurring. And yet where it seemed to reside most, there was a lack of access to physicians, to nurse practitioners, to imaging centers. So we developed a let's go to the patient approach and developed one of the first mobile programs to be able to take a CT scan and a bus platform and go to where the patients were and not only educate them, but make it very convenient for them to get screened. We published in 2000 and just came out this month in the Annals of Thoracic Surgery, but it looked at 2018 data, our first year of the mobile program. Went to 104 sites, screened 548 patients, heavy smokers, slightly majority female, and average age was 62. A significant number had lung nodules, but all those just needed observation, usually with just another scan in a year. 2% required invasive testing. We did find 5 non-small cell lung cancers, and 80% of those were in early stage with a good prognosis. The most common non-pulmonary finding was coronary artery disease or severe coronary artery disease, in which 66% of the patients had that. Also included in the vascular side of it was aortic aneurysms, severe carotid artery disease, and a lot of other vascular anomalies. Again, mostly that just needed medical therapy, needed education, and certainly presented a opportunity to hopefully save that patient from a very catastrophic illness down the road. This is a publication out this month in Annals of Thoracic Surgery. What's the end result of our work so far? We're now seeing about 50% of our patients coming in early stage lung cancer. That's up from 30%, which is about the national average. So half our patients are early stage. Our goal is to get to 70 to 80%. And to do that, we really have to capture more patients, and that's where we need your help. These patients are going to be walking into a primary care nurse practitioner's office, a vascular surgeon's office, with similar medical conditions that certainly present a red flag. What we want you to do is help open the conversation up to lung screening. We're certainly happy to do all the work for you and even bring the mobile coach to one of your offices and set up a screening site at your choice. I'm going to leave you with 2 things. Time is short. One is a documentary on Jim Allison, narrated by Woody Harrelson. It's entertaining, it's educational, and simple to understand. It gives you the insight of what's really happening in lung cancer and leaves you very optimistic. And last is our number, 495-LUNG. Call us if you have a patient or want to set up a site. We're happy to help you. We'll do all the legwork for you. I think together we can truly change the trajectory that these patients we're both seeing are on and give them a brighter future. So happy to be here with you on this 3rd annual conference for Faces of PAD, and happy to be your closing speaker. Thanks, everybody.
Well, Rob, we couldn't have had a better closing session with that, and I think that brings some hope in the sense that driving awareness produces results like that. If we can find people in stage 1 versus stage 4, that you save lives. But I do want to thank all of the participants, the attendees, for sticking with us. Over 90% of you have throughout the whole day. I'd like to also thank the speakers and their efforts to bring about a great educational event for this region. It is one of VIC's missions as a company to allow community education events and drive awareness for disease in this area. The second thing is the CME process. Survey equals CME. So look for your email from earlier today. That will have the link for the survey, which when you fill that out, that will drive your CME. Please expect that in 2 weeks via email from the TMA. So I have no ability to change that, but in about 2 weeks, TMA will be releasing the CME through your email. Please give specific feedback on this free event. Help us help you. We want to continue this event. We want to continue the drive for awareness. Did we do a good job? Where did we do a good job? Where do we need to do a better job? And lastly, I would like to close. We're going to put up all the companies that helped supported this event, and this has allowed us to drive this event and pay for all of the things we needed and make the CME free for everybody. So thank you for our sponsors, for Bard as our main sponsor, and Phillips and Gore and Terumo for the great sponsorship you did and the help for our community. So again, thank everybody for a great conference, and signing off from Vic. Please let us know if there's anything we can do for you. Thank you.